Happy to present today from, I'm from Jaipur. And we have 6 interesting cases. Unfortunately, Professor Athol Wells could not join us because he's traveling. I'm not sure about Sonia also because she's also traveling. Anyway, nevertheless, we have got our own experts from India. We have got Prahlad Prabhu Desai sir, we have got Rajan sir, we have got Mithun as a rheumatologist, we have got Vimal Raj sir as a radiologist. We have Ritu who will be joining. There are cases with histopathology today, and we have Dr. Ritu Kulshrestha as a pathologist expert. Let us see whether Murli Mohan sir also can join us in a while. And without overdue, I would request Lakshmi, who is there from Amrita Kochi, to start sharing her screen. The first case is by Dr. Shobha Madam, who is a colleague of mine, professor and head of pulmonary medicine. The second case will be Dr. Venugopal sir, who is professor and head of Alapla Medical College in Kerala. Third and fourth cases I will be presenting, and there are 2 cases from Rajan sir as well. So first case, over to you, Shobha Madam. Make it full screen, Lakshmi. Yeah. Are you there, ma'am?
Yeah, I'm here. Sorry. Yeah.
Yeah, please go ahead, ma'am.
75-year-old male, physician in government service. He practiced till 1 year back. He's from Thodupuzha, Kerala. He has comorbidities of diabetes and hypertension. And he has noticed mild degree of shortness of breath on exertion since 2019, but never bothered about his symptoms. But he has taken a CT scan at that year itself. He thinks that his symptoms have progressed in the last 2 years. They have increased to grade 2 to 3 in the last 2 weeks with lot of dry cough. No joint pains, no skin rashes, no fever, no chest pain, no orthopnea or PND. And he's a non-smoker. He has exposure to 3 hens in the compound, some 50 meters from his house, and exposure to bats residing on treetops within the compound. That's all his history. His sister has an ILD, younger sister, who is in US, and she is on MMF and Nintedanib. That's what information I got from him. He has clubbing, bilateral basal crackers, and his SpO2 on air 93%, pulse rate 64, blood pressure 150/70. And he was diagnosed to have an ILD but did not get any treatment. He did not start on any medications from 2019. And I think I have got all the serial CT tests done in 2019, 2022, and 2025. Yeah.
Shall I present the CT images, ma'am?
Yeah, please.
Okay. So these are the CT images. So quite fortunate to have multiple CTs of the same patient. I'm going to start off with the current CT just for the mediastinal window, and then I'll show the lung windows in a second. So this is a 72-year-old gentleman, and what we can see across here is atherosclerotic changes in the aorta. The pulmonary artery is dilated at 3.4 centimeters. There were small volume mediastinal lymph nodes. And as we go down, you can see these multifocal areas of splenic calcification. There are few splenic collaterals, multiple gallstones. These are all likely to be age-related and chronic in nature. When we look at his CT, these are the 3 CTs that we have. This is 2019, 2022, and this is going on to 2025. And let me start off with 2019 CT first. to begin with. And what we can see from the top itself, we start to see subpleural changes of reticulation and some cystic change, layers of cysts starting to come across here in the anterior aspect of the lungs, traction dilatation of bronchi, some degree of ground glass is also there. And as we come lower down, we can see that this all increases with more subpleural cystic changes, traction dilatation of bronchi, and a lot of ground glass opacities. So this was in 2019. Now, if we compare this, so we have 2022 and then 2025 recent scans. So this is the 2025 scan where we can see there is subpleural reticulation, honeycombing, traction dilatation of bronchi, some areas of mosaicism that can be seen. And as we come further down, you start to see these areas of traction dilatation of bronchi and layers of honeycombing, which have worsened compared to prior. The disease extent has worsened and has progressed from areas of more ground glass, has now become areas of more honeycombing in there. One of the more recent publications talk about peridiaphragmatic inflammatory fibrosis, which is what we are seeing in this case, that there is more fibrosis around the diaphragm region. This is a fibrotic ILD UIP pattern, but features are suggestive of a CTD in here rather than a typical IPF UIP. But the presence of peridiaphragmatic inflammatory findings are seen more in myositis kind of situation in people with that. So that is something which has come out more recently in few of the papers. So that would be my thought process in this patient.
So can I ask you one question, Vimal Raj sir? So this particular sign with this PDEF which you are talking about was the last time Bhavin sir also told about some pancake sign or something. So how it is different than subpleural and basal honeycombing? Because what I'm seeing is here also subpleural and basal. So how it is different than our usual subpleural basal, which is classical IPF sign, sir?
So when you look at this and the last scans towards here, these are pretty much what you would find in your typical UIP IPF. But when you start to see much before here, the inflammatory changes in the lung bases are there, but then along the diaphragm also you're seeing these inflammatory changes. And as I keep going up, you start to see these changes more towards there and across here as well. These tend not to be that very obvious in IPF. IPF tends to be more subpleural, not necessarily subdiaphragmatic in that.
So your diagnosis is CTD-ILD, sir?
UIP pattern, yeah, and CTD-ILD. I would think myositis will come top in that list because of this finding.
Yeah, Lakshmi, start sharing the screen. Question slide. Next slide.
Next slide. Yeah. CTD workup was done. Lakshmi, can you show the slides? CTD workup.
Yes, ma'am.
You have to share the entire screen, Lakshmi, then only the slides will move. Select the entire screen.
Lung function test you are not shown.
The problem is that he was coughing a lot and I was not able to get his PFT or PLCO, but I did a 6-minute walk test which showed desaturation from 93 to 72 and he could walk only 120 meters and he had 3+ dyspnea. So
Okay.
quite a lot of problem with his 6-minute walk test. Yeah, if I can have the CTD, the rheumatoid factor and ACCP were negative. If I remember, ANA profile was. Do you have the slides?
Ma'am, can you see the
Do
screen
you
now?
We can't, Lakshmi. You have
do you
to
want me to
share
share the
the
screen?
entire screen. The first option, when you start sharing the screen, left
Yeah,
upper corner,
PFT,
the first option.
PFT and DLCO not able to do desaturation from 93 to 75. That same thing I have shared. Just next slide. Yeah, this is the same thing. The test had to be stopped before 6 minutes. Next, yeah, full CTD workup was done. ANA negative, rheumatoid factor negative. Outside echo was normal 2 years back, but a recent echo showed moderate to severe PH. Next. ANA blot is negative, but myositis profile. Can I have the next slide? Yes, it showed MI2 beta 55 plus. Dr. Midun is there?
Yes, ma'am. SS.
Yeah. What is the relevance of this?
MI2 is basically a myositis specific antibody. Means it's possibility of myositis, dermatomyositis is high. MI2 is classically considered as a good prognostic antibody with classical, they usually have classical skin rash, but without skin rash also you can get. MI2 is classical for dermatomyositis.
Okay.
So easy one there.
No, I think there are a few things which I would like to comment. First of all, considering the scan, okay, the involvement of lung and compared to a patient's 6 minutes walk distance and desaturation and walking, it's highly disproportionate, I feel, in ILD. So probably we may have to find out the
Pulmonary
pulmonary,
hypertension is there.
yeah, but why patient should have pulmonary.
Yeah, I forgot to tell you. He's more on the obese side. He has snoring, excessive daytime sleepiness. So I did a sleep test also. It is also showing severe OSA as well, in addition to the ILD part. And he feels comfortable after starting the CPAP.
Still, you should rule out autoimmune liver disease or hepatosteatitis and probably underlying chronic liver disease is there or not. Because this disproportionate hypoxia he has. Sujit, you agree?
So I joined in a few minutes late. So I just to understand, Shobha, how long after starting symptoms did he present?
He started having symptoms in 2019, but took a CT scan, did not get any treatment. He's a physician.
Got it. Yeah, that's what I
read. Then since 2 years, symptoms have progressed. Till then, there was no progression as such. 2022, he took a scan. That is what he's saying. He did not get any treatment. Since few weeks, symptoms have progressed. That's what he's saying.
Would there be any reason not to suspect IPF here, Shobha?
Radiologically, there were features to suggest CTD, ILD, and he's not a smoker.
Sure, because he's got pulmonary hypertension, which is proportionate to the severity of the lung disease.
Lung damage, yes.
He's desaturating a lot. So I would treat him as IPF, but I don't know how much with no autoimmune symptoms and no other features besides a Me-too antibody positivity. I think, would you be inclined to give systemic steroid? If I had to lift the phone to Mithun on this, Mithun, have you seen the patient, Mithun?
No, I have not seen.
He just came to me only once.
Yeah.
After
there are
that,
no
he has
signs.
not come.
Yeah, there are no signs, clinical signs of autoimmune disease. Probably ignore the me too, or would you consider it significant, Mithun?
That basically these rheumatological conditions, no, we need to see the patient. Just by seeing a autoantibody, it's very difficult to say that whether
That's
you
what I
will
was
treat
not.
or not.
Correct. And looking at the age group, he's 72, right?
Yes,
75.
yes.
Yeah,
75. Family history of fibrosis. That's another
Yeah.
thing.
So I would have a very low. I mean, he's on an antifibrotic, right, Shobha?
Yeah, I have started him on that. I have not started any anti-inflammatory.
Yeah.
He's on
I think we should,
nintedanib, oxygen, CPAP, and pregabalin for his very violent cough. That's all I have given him.
So if he has a family history, he's also at risk for side effects if this is familial pulmonary fibrosis of immunomodulation. So
And his sister is on MMF and nintedanib. That's what he told me. And she's in US.
Sure. I mean, I don't think MMF is a bad idea if one is going to treat that antibody. But then you're treating an antibody, right, Prahlad?
yeah, I think we should focus on pulmonary hypertension. It's very disproportionate, I feel, compared to the lung damage.
Right.
How extensive radiologically, Vimal, you feel that lung is damaged? Just on HRCT, suppose.
25 to 30%.
Yeah, so
But
at the
he's
age
got,
of 75, which is, I think, not severe, right?
would you
But
think
he
of,
also has obstructive sleep apnea, as doctor said.
But sleep apnea as a cause for only purely pulmonary hypertension, I don't know whether it's really.
would you suspect anything besides group 3 PAH here, Prahlad?
I think we should try to find out, focus on pulmonary hypertension. Yeah, you continue antifibrotic. I'm not saying that, but we should try to find out whether he has got any shunts in the heart in the form of a chronic liver disease. If he has, if LFT abnormal, albumin
Sure.
globulin reversal ratio, platelet counts, those things to find out any other reason for him to have a pulmonary hypertension. Okay. So he hardly walked actually.
Yeah, only 120 meters. Yeah, he's very symptomatic.
Yeah, so I believe the panel says that you have to send it to Mithun and maybe you can decide on the other immunosuppressant. Are you okay? Can we move on to next
Yeah,
case,
I'm
please?
okay with that. Yeah,
Sure.
I'm okay with. Okay, thank you.
Thank you, ma'am. Dr. Praveen will be presenting. Dr. Praveen, over to you for Venugopal sir's case.
Thank you, madam.
Yeah. Please start.
Okay, ma'am. I will be presenting a case of a 63-year-old male who is hailing from Alappuzha. He's actually a construction worker. He is a long-term former smoker with a smoking index of 400, and he has got a history of coronary artery disease 5 years back. There is no history suggestive of any connective tissue disorder. He presented with the symptoms of progressive shortness of breath since 3 months with history of loss of weight and loss of appetite. And his loss of weight was significant. He lost 6 kilograms in the last 2 months. Next slide, please. On examination, he has got pan-digital grade 3 clubbing. His respiratory rate was 30 per minute and heart rate was 90 per minute. His sats were 88% room air and 98% with 2 liters of oxygen. On examination, we got bilateral fine end-inspiratory crepitation in the interscapular, infrascapular, and infraaxillary areas. Patient was, after admission, patient was little bit sick, and we just could do the spirometry, which showed mild restrictive disease, lung disease. And echo showed severe TR and severe pulmonary artery hypertension. The other investigations, his RA factor was elevated, very much elevated, and while his anti-CCP levels were low, we have done a ACE levels which also turned out to be negative. The ANA profile only centromere P protein showed strong positivity, and his ESR was 135. Other sputum TrueNAT was done, MTB not detected. His D-dimer values were 3.65. Can we go to the...
My God.
So I have CT scan of this 60-odd-year-old gentleman, and I will show you. I've got two scans which are about 2 months apart. This is the more recent of the two, where it has been done as a CT pulmonary angiogram. And what is very evident in this is there is extensive lymphadenopathy in the mediastinum. Bilateral hyla have extensive lymph nodes, and you can see across here lots and lots of lymph nodes with background of atherosclerotic change in the aorta. Now, when we look at the lung parenchyma, so these are the two scans which are 2 months apart. The left one is in August, and this is in October of this year. Both of these are around at the same time. What we are seeing is definite background of paraseptal and centrilobular emphysema, extensive nodular changes, diffuse areas of fibrosis. You can see across here there's some small cavities, and all these nodular changes more in the upper lobes, along the fissures, also very, very irregular outline across here, and areas of consolidation in both the lungs. Difference between the two scans, you can see here to here, you're starting to see a lot of ground glass in a bronchocentric distribution in the more recent scan compared to the older scan. And if I just show you the mediastinal windows again, there is a lot of infective changes in here. You can see these lymph nodes, they're quite big lymph nodes. Some of them even show areas of necrosis within them. And you can see the lung parenchyma is also showing extensive areas of irregular enhancement and necrosis. So what I have in front of me, I would be thinking first and foremost, definitely there is emphysema with secondary infective changes. I would be worried if there is a combination of TB/sarcoid, a background of granulomatous. If not, I definitely would like to think in terms of what we used to call previously bronchoalveolar cell carcinoma or carcinoma in situ in view of his loss of weight. So I think he will need a bronch and further assessment of these, because this is not very typical of an ILD. I think there's a lot of other things going on here apart from ILD in this case.
Thank you. With these findings, clinical findings and his history, we thought of ruling out tuberculosis, and from his CT findings, we also thought of sarcoidosis. As sir rightly said, we thought of this adenocarcinoma in situ as well with respect to his drastic weight loss. And we also thought of some underlying interstitial lung disease also, considering the septal changes and the clinical findings. And we did first, this FOB was done after the first CT, and we did a bronchoscopy, and the bronchoscopic findings were normal. We took bronchial washings. During the procedure, we were planning to take a TBLB as well, but during the procedure, patients started desaturating, and we abandoned the procedure. Bronchial washings were taken. And after the procedure, patient had some respiratory distress, and he developed some sort of, we think it is a pulmonary edema that may be the cause of the increased alveolar opacity seen in the second CT. We are not sure. But patient improved and shifted back from ICU. In the bronchial wash study, cytology turned out to be negative. Gene expert was negative, but AFP smear turned out to be positive 1+. Next slide, please. So in view of BAL, AFB positive and CBNAT negative, we thought of the possibility of NTM. NTM treatment was not started because we are awaiting the AFB culture report and possible species identification of NTM. And patient is currently not willing, right now he is not willing for a repeat procedure. And we are, meanwhile, we are awaiting your expert opinion as well. So this is a case of 63-year-old male from Alappuzha who is a construction worker with smoking index of 400, presented with a 3 months history of dyspnea, loss of weight and loss of appetite, RA factor elevated, anti-CCP negative, ANA profile, centromere PB protein strong positive, ACE levels were normal, ESR is elevated, and his spirometry showed a mild restricted disease with his, of course, his BAL findings.
Any question you want to put?
So, Praveen, why would you suspect NTM in him? He had, one would assume this was a normal host, right? Without any structural lung disease in the past. So to get that extensive NTM, he's not immunocompromised in any way, right?
Yes, sir. We are not considering it as the first possibility, sir. We are just
Yeah.
awaiting the results only, sir.
Sure, sure. Because the smear is positive and
Yes,
the CB-NAT is negative.
negative.
That's that I can understand. That I can completely understand.
Sujit, can I speak for a moment? I'm having a bad respiratory infection. That's why I asked Praveen to present it fully.
Sure, sure.
Yeah. This is because we didn't think of NTM. We thought either tuberculosis or sarcoidosis.
Yes.
And also BAC was one differential diagnosis, bronchoalveolar carcinoma, which is now renamed as adenocarcinoma.
Yeah.
But once the BAL came then we are in a doubt because AFB positive and NTM negative. So that's why only we are thinking of NTM.
Correct.
But we want to repeat a BAL and confirm that, but then he's not willing for another BAL. And sputum is negative.
Right.
So that is our confusion. It's not typical for NTM. At the same time, this positivity of rheumatoid arthritis RA factor and that centromere antibody, this also came positive. So is there an underlying ILD? That's one question. Or is purely some TB or NTM? That's our doubt. So we would like to have an expert opinion from you.
How many days ago was the bronch done? Do you know?
Almost now it's almost 1 month or 3 weeks.
3 weeks ago.
Yeah.
So you have a bronch done 3 weeks ago. You another 3 weeks to go for the AFB cultures. And how is he clinically? He's not running fever. He's
no
weight
fever.
loss. Nothing.
No. Only his dyspnea is there, and he's a severe PH. Another reason that we don't know. Maybe because of the emphysema also, but there is no other reason for that pulmonary artery hypertension, which is severe also.
A severe PH can be due to this anti-centromere antibody. Many patients, they may not have the skin disease. Anti-centromere antibody is closely associated with severe PH.
Okay.
Can you go back, Vimal, to the scans again? See,
so that's why there's a lot of ground glassing. So is there an ILD also? That's what your doubt.
So this is basically an ex-smoker. He has an emphysema inside.
Yes.
He has necrotic lymph nodes, and necrotic lymph nodes generally do not happen in adenocarcinoma. Okay, and he is a construction worker also. Okay, are these? Can it be a combination of a silicosis with Kaplan syndrome type of feature? Okay, where you have areas of RF strongly positive, ESR is high, antisyndromic antibody plus minus become positive. And there is a definitely areas of fibrosis, nodularity is there. You can have that in a silicosis, silicotuberculosis, or maybe a silico Kaplan syndrome type of feature with severe pulmonary hypertension and TR, because a TB will never come like this. Okay, I don't think so. You have to have symptomatology, and AB negative means almost gone. A typical mycobacteria will not really present like this. This whatever you are getting AB positive could be a Mycobacterium chiloni, rapid growers, which can happen in your bowel contamination. I feel so. Okay, so that
Yes,
is
Prahlad, that is a possibility. Actually, we thought of this silicoproteinosis because a lot of areas showing severe ground glassing is there, plus lymph node, plus this nodules. We did think of silicosis, but then this AF became positive. So if it's silico TB or something, that's our differential diagnosis.
So if you have a Lawat sample, if you can go I don't think now it is useful, but you can see the past staining in that, see whether the proteinous material is, it's a combination of disease. Okay.
There's a lot of subpleural component, no,
Yeah.
Prahlad. What
Yeah,
if,
yeah, yeah.
Vimal, would you stick a needle into that consolidation subpleurally?
So I would do two things because there are a lot of these necrotic lymph nodes. I would first get an ultrasound of the neck to see if there are any lymph nodes there, and it may be very easy for us to stick a needle there and get a sample from there. But
Right.
otherwise, these lesions here are very easy to biopsy.
Yeah.
Correct.
So I think in our center, Venu, we would probably put a needle into one of those lesions that Vimal pointed out to, or the subpleural lesion, where you're
Okay.
even safer,
CT,
Yeah,
CT guided FNAC?
CT guided biopsy.
CT guided biopsy.
Yeah, biopsy, not
Okay,
FNAC, with a true cut needle.
Or we can go for EBUS also, no?
It's too much. EBUS
It's
is
a
not
bit
required.
complicated, no, to get all that done. It's simpler to do a CT guided biopsy, in my opinion. Again, it depends on operator comfort, because now with the bronch, he desaturated.
Yeah,
With
that's
the
one.
CT and an anesthesiologist standby, keep him on oxygen and do the procedure. He just has to do a breath hold for some time.
Okay. So we'll try for that because he was not willing for any more intervention. That's what
Yeah.
we
He
were
may not
waiting.
be
Anyway.
even ready for the CT guided biopsy, I think. And then you have a real problem on hand because there's a lot of things going on there, and
Okay.
which you need some answer. Empirical treatments here are not going to make sense, in my opinion.
Okay, we'll try for that then. I'll let you know the feedback. Okay.
Thank you.
Thank you all. Thank you all.
Interesting case.
Thanks. Interesting.
Yeah, I wanted Marine to present, but because she could not join, I'll start presenting my case. This 62 years old gentleman from Kottayam who presented to me with cough for 6 months. He also had dyspnea on exertion for last 2 to 3 months, which is like grade 2 to 3, which is for 6 months again. He was on inhaler, but irregular inhaler, working in textile industry, systemic hypertension, schizophrenia. He was on olanzapine for last 25 years. Can you move to next? Yeah. So when I examined previous slide, Lakshmi. So his vitals were very much stable when I examined. However, he had bilateral rhonchi present, even audible wheeze. Sometimes he's telling that when he climbed stairs, there was a wheeze present, and he had history of olanzapine. That is again I'm telling, but we will come to the point why I'm saying that again. Next slide. His spirometry was FEV1 of 67, 65, FVC of 67, ratio of 77, DLCO was 91, and FeNO was also done, that is 28 parts per billion. Vitals, if you will see, there was a 63% eosinophil count. I'm not sure why it has not come in the slide, but his total count were 13,000. His neutrophils were hardly 30%, and rest of them were 63% eosinophil. Actually, he came to me for the evaluation of eosinophilia, and his IgE level was greater than 2500. Rest other investigations were okay. Next slides. This all investigations were done outside. We by the time he came to me, his USG abdomen pelvis was done. He was nicely worked up for eosinophilia. His bone marrow biopsy was hypercellular, and they did work up for multiple myeloma, monoclonal gammopathies, HES, PDGFR alpha. Everything was done, which was found to be negative. Now the next slide, if it is CT scan, I think Vimal Raj sir. I'll stop here and we can do CT scan, sir. You muted, sir.
This is the CT scan of the 62-year-old, and I'll come from top. Nothing much going on in the mediastinal window, so I'll come straight into the lung window. What you're seeing here are these patchy areas of ground glass, nodular opacities in the lungs bilaterally, tiny nodules which are spread across the lungs bilaterally, and upper lobes, as well as we come down lower lobes, also you're seeing very, very small, fine nodular changes. Not much in terms of consolidation, not much in terms of reticulation or traction dilatation of bronchi, but you're seeing these ground glass changes all across. And as I come lower down, also you're seeing this. You can see mild bronchial wall thickening in the lower lobes, but otherwise slight mosaicism is there in the lungs, but otherwise these diffuse ground glass opacities are seen from top to bottom in the lungs. There is coronary artery disease related changes. There was not much in terms of lymph nodes. The pulmonary arteries were also within normal limits in this patient. So what we are looking in here is diffuse, fine ground glass nodular changes in both lungs, upper and lower lobe involvement. There is no predilection, bronchocentric in distribution, no features of fibrosis. So acute hypersensitivity pneumonitis with one possibility. With that degree of eosinophilia, one would also think about eosinophilic lung that we are looking at in here.
So the reason I have put this case in ILD is when I discussed with my radiologist, they told that this particular thing goes more in favor of drug-induced ILD or HP. And even though I was initially planning to do just BAL as a part of workup, I went ahead and did biopsy also because our radiologist's first diagnosis was HP. As you rightly said, they also told there is a centrilobular nodules, and even though it is very fine, the HP was his first possibility, and that is why we did. He doesn't have any exposure history. By any chance, do you feel this fits into ABPA, sir?
No, not into
No,
ABPA. I don't think it
he
is
doesn't have
ABPA.
his asthma. Even though IG was greater than 2500, I just wanted to ask you that. So yeah. So Lakshmi, our slides, please. Next slide. Bronchoscopy was normal. We did lavage and we did actually biopsy from the right side. And Ritu madam, if you can see and
Yeah.
say.
Yes. So this is in this slide, the right side image which is there is low power, which is showing one endobronchial bit and one transbronchial alveolar tissue bit. The left side picture is showing an exudate. So that's all that we can make out at this magnification. And let's go to the next slide, please. Okay, so the next slide, again, on the left-hand side, we can make out the pseudostratified ciliated columnar epithelium, the subepithelium, and we can see some amount of mucin acini which are there below it. The right side image is showing a sub-epithelial cluster of inflammatory cells, which if you zoom in and into this image, you'll be able to see that they're comprising of some cells which have got a little, orangeophilic kind of a cytoplasm. So you'll have to believe me that this is the collection of eosinophils, which is under the bronchular epithelium. Next slide, please. So this is from the exudative tissue and from the alveolar tissue, where you can see that there is now a cluster of inflammatory cells, and the eosinophils are predominantly dominating the picture. They can be seen as bilobe nucleus with kind of orangeophilic cytoplasm as compared to the other cells, which are the plasma cells, lymphocytes, and the macrophages. Next, please. So this is from the exudative part, and again, a lot of inflammation there. Not much of tissue that I can comment upon, tissue reaction or alveolar tissue, but inflammation is definitely present. Next. Okay, that's it.
So my pathologist also called me specifically for this patient. If we are seeing BAL eosinophilia, I think the BAL eosinophilia was amounting to around more than 20 to 50% in this particular. 70% was BAL eosinophilia, if I remember correctly. And even biopsy, she was very much sure about that the bronchial tissue. She was not having any problem with the lung inflammation showing a eosinophil. She had more problem with the bronchial tissue showing eosinophilia. So that is what she was telling, that is a very very rare thing which usually we do not come across if there is a bronchial inflammation which is showing eosinophil. Do you think like that, ma'am?
We do get eosinophils in the peribronchial, and then I usually I'm worried about whether I'm dealing with a Churg-Strauss or an asthmatic patient underlying. So I don't know in this case.
Yeah, I think did I show that workup, Lakshmi? It is NPO anti-PR3 negative, ma'am. And next slide. Next, 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 next. Questions. Yeah, so is this drug induced to ILD? So why I put olanzapine is after seeing this particular thing, I found out that olanzapine can cause even amounting 70% eosinophilia. Though patient was on 25 years for 25 years on this drug, he gets free medicine from his ex-serviceman benefit, and the brand is changed every time. And he's telling that for last 6 months the brand was changed, and that is why this is happening. He's not at all willing to stop the medicine, so that's out of question. So now I have to deal with other than stopping the medicine. So do we have any other option? And does CEP, chronic eosinophilic pneumonia, fall under ILD spectrum? This is for Vimal Raj sir. Do you think so, sir? You muted.
I'm smiling because that is a question I also don't understand. I've gone through the whole thing and I'm not able to face
Yeah.
it. So if anybody else has an opinion on that, I would be happy to hear. I do not.
Rajan sir and Prahlad sir also. Yeah, we don't know. Like, I don't know, but they have put that in the classification, isn't it, sir?
Yeah.
They have put this
They have
terminology. Yeah.
mentioned it, but
Yes.
it's very ambiguous in the manner in which they have said, and it's not as crystal clear as I would like it to be.
Yeah, they have put it in the alveolar filling and infiltrative disease pattern, right?
Yeah.
Okay. Yeah, so that's it. And steroid therapy, I will start steroids. I have already started.
You
That's
have to
what
be
I
very
will. I'm not
careful.
going to do bone marrow.
No, Smita, I would be very careful with steroids here. He's a schizophrenic. And you give him steroids, his mood is going to go. See, he's already not willing to stop olanzapine. So you'll have to
He's
weigh
not.
the pros and cons of giving him steroids versus changing the antipsychotic. Can't the psychiatrist change the antipsychotic?
I told him to get admitted, and psychiatrist he's consulting outside. He's not willing. However, I told him to go back to the previous brand, which he's willing, which he agreed that even if he has to buy on his own pocket money, he will do that, and that I'm going to do. And as you rightly said, I was worrying about psychosis, steroid-induced psychosis, and it can worsen. So we are being very careful about the dose which we are giving, sir. We will be giving minimum dose possible. I'm going to follow up very frequently to him. We'll keep under. He has his own issues, not willing. Even this biopsy I did was on OPD basis. He won't get admitted. He's saying that he has his own issues. He won't get admitted. So that part is not willing. Psychiatrist, I thought even changing of medicine is possible, but he won't change. He's telling I can't survive without that.
Yeah, it would have
So the
been
only
good to
reason.
have the psychiatrist on this call, because this is a patient we would always discuss with the psychiatrist what to do. And because the mental health and the drugs that we're going to give him are going to affect his mental health. So it's his lungs and his mental health, both that have to be managed together. It is tricky. We've had such
And the second
patients.
question, sir, this ERS,
Yeah.
do you put this as an ILD, sir, CEP?
So, I mean, this would be an interstitial lung disease by any criteria. Chronic eosinophilic pneumonia, I think, would fit in. You're getting a lot of bowel eosinophils. To me, this is a drug-induced interstitial lung disease, eosinophilic lung disease. And the only thing is, Ritu is not seeing tissue eosinophilia, right? We're only seeing it in the airway. That's a little odd. And usually the criteria is that you should see it in the tissue as well. So I do think this is a
Yes.
drug-induced ILE. That would be the diagnosis, but I think the management here is going to be challenging and should be done with the psychiatrist. That's Prahlad.
Yeah, I think he's on only on olanzapine. So it means his schizophrenia must not be very severe. Okay. And he's managed for us so many 25 years. Um, the diagnosis will be chronic pulmonary eosinophilia, which is more than 6 months. Okay. Now, um, try to find out other causes of pulmonary eosinophilia before we consider for only olanzapine induced, though it is been reported. Steroid is
Yes, sir.
not really high dose required in this patient, Sujit. I feel like 20 milligram Visolon will be sufficient enough and to see the response. Diffusion is how much affected or it's not done? Dif-
Not affected. He's okay. PFT is restrictive, but
yeah.
diffusion is 91%.
So that indicates that interstitium is fairly good.
It's
6 minutes walk
Yes, sir.
distance also
Yes, sir.
will be useful to
It's not,
differentiate.
yeah, he's okay.
Yeah, so it's a
Mhm.
it's a pulmonary eosinophilia where you may have normal lung function tests.
which is why I'm not sure what we are going to be treating.
Sujit,
Which is
suppose we are not discussing in ILD this case. Tropical eosinophilia, chronic tropical eosinophilia, what earlier when college days we used to see such patient, nodular shadows in the lung with
yeah,
eosinophil counts so high. So we used to treat this patient with empirically hetrazan, with of course finding out stool routine and finding out worms, deworming them and all those things. Can it be
Yeah.
tried first?
of
So
course.
this patient, yeah, so this patient has already received all because he is being
Already.
evaluated for eosinophilia.
Okay.
So all those things has been tried and
Gone.
tested.
Okay.
Yes.
Fine.
So he's received 4 weeks of diethylcarbamazine.
Yes, sir. Yes, sir. Everything they only steroids were never given, which I started, and the only thing which I asked specifically because I have not yet sent ABPA workup. IG was greater than 2500, so I'll finish. I'll do that also.
It's not
Just to be honest,
ABPA. It doesn't look
yeah,
like ABPA at all.
doesn't look like, yeah,
What are his
only
symptoms
IG.
right now? How affected is he
We
functionally?
so dyspnea on exertion and cough, dry cough. So he has symptoms, sir. He
He
can't
is
walk much
breathless.
because of these. Yeah, these.
Yeah. I mean, having managed a few, I would say at least half a dozen patients with psychiatric comorbidity and hypersensitivity pneumonitis, it is challenging, Asmita. And I
Yes.
would lift the phone to the psychiatrist and have a chat with them because it has to be co-managed.
I totally agree, and I would have done the same. But the psychiatrist is not from my hospital, but I'll try to do it. I'll find the number and do it,
But
sir.
that
Thank
shouldn't
you.
prevent you from calling him.
Yes, sir. Yes, sir. I'll do that. Okay, moving on to the next case. Next slide, Lakshmi. So she is a 58-year lady from Kerala. She is a homemaker. She presented with dry cough dyspnea for last 1 month. She also has loss of weight and loss of appetite, maybe 2 to 3 kilo, not much. Diabetes, hyperlipidemia. Next slide. So she has occupational history. Her son is running a flour mill, and she used to assist him 1.5 years before for 6 months, and she stopped it. She has history of 1.5 month before she had exposure to birds on her terrace. Every morning when she used to clean the terrace, there was one small baby bird died. 4 days continuously it happened. She feels that all her symptoms, which she is suffering right now, started only 1.5 months. She worked in the flour mill for 6 months, 1.5 years before. This is 1.5 months before which happened. How much significant it is, I don't know. And her onset of symptoms were following after exposure. It's not started with the floor mill exposure. She was desaturating when she came to me, 92% on room air saturation, and I could hear inspiratory squeaks. Rest all the examination was normal. Next slide. So here again we have eosinophil count of 37% for my patient, and 14,000 were total counts. Rest all the things were normal except the ESR, which was on a higher side. Next slide. Total eosinophil were 3,264. IG was greater than 2,500. and anti-MPO, anti-PR3 was negative. Next slide. So other than 6-minute walk test and DLCO, which was 36%, her investigations were normal. She desaturated surprisingly from 95 to 89%, covered only 300 meters, and she is in her 50s. That was very shocking. But PFT-wise spirometry was okay. I'll stop sharing screen now and maybe sir can show them.
So this is the CT scan of this 58-year-old female. A couple of things I would like to point out before going into the lung windows. She's got a lot of prominent right axillary lymph nodes. They are quite chunky and they are rounded. They don't look normalish in there. I don't see any breast lesions. In the mediastinum also, there are a few prominent lymph nodes. The mediastinal lymph nodes are not big, but the right axillary lymph nodes are big. And then there is a small hiatus hernia also that we can see in her. When we come into her lungs, this is her CT scan. Similar to the previous case, but with more than that, we are seeing this diffuse ground glass, bronchocentric nodular areas, but more widespread compared to the previous scan that we can see. Upper lobes are involved, patchy areas of increased ground glass in the background of diffusely increased haziness in the lungs. Not much of traction dilatation of bronchi. And mild septal thickening is started to come in towards the lower lobes. Patchy areas of atelectasis and some fibrosis in the left lower lobe, but this I think is not related to the current process, what is going on. And when we do an expiratory scan for her, what you're seeing in that expiratory scan are some areas of air trapping, which we can clearly see across here, especially in the upper lobes. And further down when we go, not much in terms of air trapping. But so overall, I think, again, very similar to the last case, this is looking more like an acute inflammatory process. Would think in terms of hypersensitivity pneumonitis going on in this patient. The lymph nodes, I am worried with the history of loss of weight. We've seen few of these lymph nodes. We've sampled and they've come back as TB positive in their isolated. So those would be the two things that I would be considering in this person.
So the radiologist who reported the CT from outside, these are all outside CT scan, which she came with. Only expiratory CT is what I did or requested her to do. So they did mammogram, sir, and the mammogram is the like thyroids, and they didn't suggest biopsy. They suggested that okay, we'll keep under follow up. I also found that the axillary lymph node is too huge to do, but do we think that the lung pathology also can be correlating with the axillary lymph, or both are different pathology? So I didn't go after that axillary lymph node.
I don't think the lung pathology is severe enough to account for the right axillary lymph nodes. I think they are separate. I would at minimum do an ultrasound of the axillary lymph nodes to just see what is the flow pattern in them, and if the flow pattern is abnormal, would put a needle into that. I think that might be a simple thing to do. You know.
Okay. Yeah, I'll tell. Yeah, you can share the screen. I would. So again, this patient, like go to the next slide. Next. We did actually bronchoscopy, and the smallest lymph node also we did EBUS. We found in this particular patient, surprisingly, there was no Ball eosinophilia, and everything else was normal. Lymphocytes were amounting to 20%. We started doing Ball lymphocytes and Ball neutrophils after your talk, Rajan sir, about that particular thing which you showed, and that is a good addition. Next slide.
Yeah.
So, Ritu madam, if
Right. So here we have on the left hand side, we have two endobronchial biopsies, and the upper third bit which is there is the alveolar tissue. And on the right side image which is there is showing some amount of architectural distortion There is air trapping, there are dilated air spaces, and in between there are areas of fibrosis which are mixed. So it is cellular as well as fibrotic. So we like to see this under higher power, both the endobronchial and the alveolar tissue bits. Next slide, please. Yeah. So this is the higher power where they are showing the on the left hand side image. They are showing that the air trapping is there, almost like leading to an emphysematous change, and there is some accumulation of eosinophilic material here, which is pale and eosinophilic, but the surrounding interstitium is in this area is not fibrous, but it is more cellular in nature. And as we go to the next slide, we will see that the cellular infiltrate that is there is mainly again those orangophilic looking cells interspersed with the lymphocytes. So here there is, in this right side and left side picture, there's some amount of mixed cellular and fibrotic change in the interstitium with this kind of air trapping which is going on. So again, we are dealing with an eosinophilic lung disease here. There's no granuloma formation. There is no fibrin material. There's something which we saw earlier in some of the spaces which could pass off as maybe alveolar proteinosis, but these are the images which we have. Any other slide? No.
No, that's it, ma'am.
Yeah.
So next slide, Lakshmi. Can we go to the question directly? Yeah, so the questions were again the same, that is it HP and EP overlap, or is it something like only because there is no granuloma, so there is no HP happening at all. Or Vimalraj sir, do you feel that eosinophilic pneumonia alone can explain all the findings which are there on CT scan? Or again, Prahlad sir told that this is tropical pulmonary eosinophilia. Somebody even suggested that I should do antigen for file area and all. I don't know whether such antigen checking exists, because even though in Kerala I have never seen such things happening. Most of the times we just give DEC that rather than finding one. So those are the questions. And should I give steroids? Will it be sufficient?
When did Prahlad say it's tropical eosinophilia?
No. The previous case he sir
Ah,
told
the
na that
previous
we
case.
both
Yeah.
are so similar cases.
Sorry.
Yeah, both are similar cases. That's why.
But this patient didn't have peripheral eosinophilia, did he? Or he had
37%,
37%. 37.
3,000. Yeah, this person. So almost similar case happened in the same time. However, in this patient, I was not expecting biopsy showing eosinophilia. And that is why. The previous case, though, we knew that there is eosinophilia. This was like HP or something else because of floor meal exposure. And also in some studies, they have written that HP can present as eosinophilic pneumonia in biopsy. What do you say, Ritu madam? Can it?
Yeah, it can.
Actually, it can, but there is not actually the quantification of number of eosinophils is not clearly there. So here in this case, if you are seeing, there's a lot of interstitial change going on. There's cellular inflammation and fibrosis, and there is air trapping, and it is. But since there's no granuloma formation at all on this biopsy bit, we don't know if it is there somewhere else. So whether it could be, one of those areas where the eosinophilic infiltrate is more. So that cannot be pinpointed.
Yeah.
I think this patient is little different from previous because here there is a pulmonary eosinophilia which is associated with hypoxia and diffusion defect. Okay. He has also lymphadenopathy, which is there and which is significant. As Vimal said, that may correlate, may not be correlating, but we may try to correlate that. Sometimes drug-induced interstitial pneumonias can associate with lymphadenopathy also. Okay. So, was he on any homeopathy, Ayurvedic, or any other drug for or
No,
anything
sir.
going on? Floor
No.
mill workers can get silicosis, but if she is actually stone breaking while doing, but
Hmm.
otherwise, uh, so this is a little difficult case to say what exactly, and probably therapeutic trial only will help us.
So anyway,
Steroids,
you
right?
didn't give
Therapeutic
him,
trial of.
yeah, but why didn't you give him diethylcarbamazine before doing the biopsy, Asmita?
Yeah, so I will confess that I did not see 37% eosinophil before my pathologist called me. And
Okay.
after that, I went back and saw that, oh, there was 37% eosinophil because these two cases went together. One diagnosis HP and one diagnosed the previous case. And she was like, even this patient is showing eosinophilia. Then I went back and told her that, okay, there is a peripheral blood. So that was a surprise. And I have to confess that I did not notice it previously. So that is why, and I would have given trial. Yeah. So I believe that we will give a trial of DEC as well as. Are you aware of some filarial antigens, or have you ever done it? I have never heard of it. Even though I am in Kerala for last 10-15 years, somebody suggested that, oh, you could
Acute,
have done this, you
acute,
could have done
acute
that.
filarial infection, na, when you have got acute filarial infection, the blood can show, okay, but an antigen also can be detected. But I don't think in this patient generally we get positivity.
But it is checked on peripheral smear, na, sir. We can find
Hmm.
out. My pathologist will say me if it was there in the PS. Right, ma'am? Ritu ma'am? Right?
No, but the chances of getting on the peripheral smear are, I mean, very less
There.
actually.
Very rare. Yeah.
Lymph
Yeah.
node, lymph
Anyway, we
node
will move on.
biopsy we should try to do and find out whether
Yeah,
this also shows
Yes, sir,
better on
I'll
the
do.
lymph node. We've got it on the lymph node FNACs many times, which we've
that you
picked
can
up.
get because that's a
Okay,
Yeah,
sir.
but
I'll do
before
that.
you put in
Lakshmi
a
asked.
needle into that lymph node, I think, see the response to DC and then take it from there, no? Maybe.
I'll do
I
that.
want to ask you one question. Whenever there's such a peripheral eosinophilia, when we refer to hematologists for bone marrow biopsy, they said ki nothing you will get unless you are thinking about eosinophilic leukemia or something. They used to ask us to do a JAK2 mutation. I don't know, but Ritu, what do you think in such eosinophilia, peripheral eosinophilia, which is significant? Does the marrow is useful, important test or no?
So I think it depends upon from where we're getting the patient, because when we were posted in Nepal, we used to get a lot of Kala Azar and LD bodies, sir. So it
Okay,
used to be, oh, sir. So it depends on where the patient is coming from, sir.
okay.
Yes, sir.
Okay,
Yeah, make it
so
slideshow.
yeah, this is a 58-year-old cardiac surgeon in Mumbai. Never smoker, workaholic, travels a lot. Noticed an increased effort tolerance on stairs the last 6 months. Mild early morning cough, occasionally bad bouts while he operates. He has vocal nodules. Exercise is minimal, no autoimmune symptoms, and exposures to damp walls and mold uh, are there at home. Past and family history, hypertensive and a diabetic. He has an iatrogenic urethral stricture which developed when he had cerebral malaria more than 20 years ago. He pulled out the catheter at that time, and that's how that happened. And then he had a mild COVID attack in 2020, but we don't. A CT was done then, was abnormal. But as far as I know, Vimal, I don't think we have that scan, right? 2020 was not there. His youngest brother has ankylosing spondylitis. He saturates normally. He's operating, he's traveling, he's currently abroad. It's fine Velcro crackles in the right infrascapular area. And his blood work has been done, as you can see. And Pooja is also on the call from the ICMR lab, and she had run his myositis antibodies. They were 1 plus, Me2 and PMSCLs, very weakly positive, HP panel negative. A1C is reasonably controlled. Echo is okay. Pulmonary artery systolic pressure 34. He's on amlodipine and tell me for his hypertension. And this have been his lung functions that he's had over the years. And you can see there's a very gradual drop in those lung functions. And because he doesn't exercise, he only noticed the last 6 months that he was getting a little more breathless. And then I think we have a couple of scans, Vimal, or one. So
We just have one scan, actually.
we just have one scan, and I think, yeah, if you could, we could see that scan. Is DLCO reasonably well preserved?
So this is his scan, and first thing
In
is that
November 24, there was no scan, Vimal?
I did not get the November scan. I've got a
Okay.
September 25 scan.
Oh, okay.
In memory, I have seen it. His son had shown it to me, so I have seen it in past, but I
Okay.
don't have that.
Okay, sure.
So the main pulmonary artery is dilated at 39 millimeters, small volume mediastinal lymph nodes. It's got diffuse fatty infiltration of the liver. And when we look at his lung, what we see are these diffuse interstitial changes predominantly in the periphery, where we can see patchy ground glass opacities with some reticular changes. There are a few scattered nodules within this that we can see. And as we come down towards the lung base, we start to see more of traction dilatation of bronchi is coming in, and you can see again more cystic changes likely to represent early stages of honeycombing that we can see here getting to establish. The extreme lung bases, some parts are not involved, so that goes against a UIP pattern. This is more in keeping with an NSIP pattern. And again, the peridiaphragmatic changes are again something very prominent in here, so that would be a consideration. On expiration, not much in terms of air trapping that we can see here in this patient. So overall, we are dealing with a fibrotic interstitial lung disease. This is patchy ground glass, traction dilatation bronchi, very early stages of possible honeycombing starting in across here. Would be thinking in terms of a CTD ILD in this patient.
Yeah, and so these were the scans, and Smita, if you can pull up the question I had. Yeah. So this was the myositis blot. Mithun is here.
Yes, sir.
Yeah, Mithun is also here,
Yeah.
and Pooja is also here. So these are very weakly positive antibodies. Next slide. And this was the single nucleotide polymorphisms MUC5B. Can you just tell us a little about these two things, Pooja, his MUC5B and TOLIP?
Yes, sir. So here, since MUC5B has GT, it is not very conclusive. Since it is not completely GG, neither it is TT. So if it is TT, it increases the production, like overproduction of mucus. So like depends what is the diagnosis, what is the working diagnosis. So here it cannot be taken as a conclusive result, like GT.
Sure.
Yeah. And also for TOLIP,
The
which is
next
in
slide.
next slide.
Smita? Yeah.
So here it is CT. If considering this patient for NAC, so this T cannot be considered as very safe, since T is safe for NAC NAC treatment, but single T not very sure like if it is safe for NAC or not, because it still falls in between like CC and TT. So again, not conclusive.
Sure. So we aren't giving him NAC. In fact, I think the questions, next slide, is, so to summarize, this is Prahlad. I'd really like your thought, and Mithun as well, because of that myositis, diabetic hypertensive, urethral strictures. He's had 3 UTIs in the last 2 years. The latest scan has a left lower lobe nodule as well, Vimal. That was what was Bhavin had reported.
That's right.
How
Upper lobe,
large
I
is the
think.
nodule?
Let me just tell you. 10 millimeters.
10 millimeter, yeah. So you'd obviously want a fresh scan in 3 months then, Vimal?
Definitely, yeah.
Yeah, so he's planning to do that in December. For the cough, I'd advise lifestyle changes because there's a lot of symptoms of reflux, Prahlad,
Yeah.
and an endoscopy, and to repeat the scan in December. Now, the question is, should we biopsy? He's had a 9% drop in FVC in the last 10 months. Immunomodulation, antifibrotic. This is the question I had. Should we biopsy such a gentleman or not? And Asmita, if you
Sujit,
back to the lung function, Asmita.
Sujit, I feel he has
Previous
a
slides.
Yeah. Yeah, go
okay.
ahead.
I feel his brother has ankylosing spondylosis. Okay.
Yes.
So with this scan which we will describe, okay, she must be having some sort of autoimmune disease. Okay, we don't know what. Okay, though the markers are not very expressive. So we should, when you are repeating a scan, rather than repeat a whole body PET scan, and see whether any other organ involvement is there on the PET scan, which probably may be helpful to us to evaluate the nodule also. What is there?
Okay, that's yeah, I did think about that. Yeah, that's right. I mean, not a PET CT, to be honest, but I think they
Because
wanted other.
ankylosing spondylosis can be associated with many autoimmune disorders, okay, in brotherly families.
Correct.
They can manifest in this
Mithun?
patient.
Mithun?
Sir, regarding the ankylosing spondylitis, we have two types of disease. One is CTDs or
Yeah.
autoimmune disorders, and ankylosing spondylitis comes in the inflammatory spectrum, like a auto-inflammatory type of thing. That means there is no antibodies. It's basically a more of an innate immunity mediated thing. Therefore,
Inflammation.
it's a inflammatory. Therefore, not like if your patient brother had RA or SLE, there is a very high chance of in the this patient also having some autoimmune diseases. Ankylosing spondylitis, he can get those type of diseases like angspond or Behçet type of auto-inflammatory conditions where ILE is not a very common manifestation. But
Yeah,
but
inflammatory bowel disorder also is common, na?
yeah, yes. And angspond, IBD, those type of diseases can occur. Not
Great.
like dermatomyositis. Dermatomyositis can occur due to other reasons. But family history wise, if you see, we don't consider it as a risk factor for dermatomyositis or a CTD, angstmon.
Okay.
You can get IBD, Behçet's, those type of diseases.
Okay. So I think after this recent drop in lung function, he's got a bit worried. And obviously his lifestyle is very, very chaotic. So, Prahlad, what would you advise him? I mean, what would your thought be? Wait.
I think he's dropping lung function pretty fast because in 5 years, more than a liter he has dropped, 1.5 liter.
Yeah. I mean, 7 years. 7 years he's dropped almost a liter. And
4
yeah, 10% in the last 8 months.
So his progress is fast. So since he has gone abroad, once he comes back, I think whole body PET scan you do and see whether anything you can
He's
proceed with.
currently traveling abroad, and he's coming back. And so,
suppose
in fact, I
empirically,
was hoping the pulmonologist who has been seen. I saw him for the first time couple of weeks ago. The
his
pulmonologist.
pulmonary hypertension, Sujit, what Vimal has shown that pulmonary artery size, I have never seen such a huge pulmonary artery, and with in this with the aorta compare, if you see the pulmonary artery size is pretty high. Okay, so I think we have to, and he's an obese person. Your echo is underestimating pulmonary hypertension.
He's not. He's not obese. He's overweight. Yeah, I wouldn't call him obese. He's a big-built guy, tall. Sumit Singhania has been managing him and wanted to be on this call, but he's got a talk at NAPCON right now, so couldn't join the call. Yeah, can we go back to the last slide, Asmita? So I think the question still remains whether we should do a biopsy or not, or bring him back for discussion with Sumit there. at the next MDD, because he's very keen to know whether he should take immunomodulation, antifibrotics. I don't know if he'll be ready for a biopsy. Usually, cardiac surgeons could be reluctant. I'm not sure how easily he would agree.
Antifibrotic, why we should not start? Because he has honeycombing.
Just a hint of it now, no, Prahlad. It's not
Yeah,
like
but
typical
he has got
neurology
a
pattern.
10 significant lung loss, volume loss.
It's
It is more safer than empirically starting.
I mean,
immunotherapy.
I'm just trying to think, you have to put yourself in a physician's place, right? And see what he would want here. I would think I'd want tissue to be looked at, no, Prahlad, or not?
You will get only fibrosis, I feel.
You feel so too, Vimal?
I think, see, the couple of things. I have the advantage of having seen his prior scans also.
Yeah.
His son is a student of mine, and he had shown it to me. There is
Right.
definitely progression of disease
Right.
in the scans. Slow but definite progression of disease.
Right.
I totally agree with Prahlad that the 10 millimeter nodule will also be something very well assessed with a PET CT
Yeah.
that we should do.
Yeah.
Antifibrotics, I would have taken it if I was in his place. I definitely would have taken it. And
Sure.
biopsy, I am sure there are areas which will show you inflammatory tissue, not end-stage fibrosis. You will get those by EBUS and core biopsies, but I don't know how useful they will be.
So
Not very.
Vimal, his lifestyle is such that the guy eats late and just lies down. So I told him to get an upper GI endoscopy done. Could this, just be reflux related changes? That's what I thought I might see some. No, you don't think so?
No,
Okay.
I think it's quite extensive. Upper
Right.
lobes are significantly involved bilaterally.
Sure.
Doesn't.
So then I think I will talk to him about
If you
antifibrotic.
want to do a biopsy, what biopsy you are planning? VAD biopsy?
Lung only.
Lung, but
Right.
Looking at the
biopsy.
autoimmune component, reflux component, you see some changes related to reflux. Sometimes, little granuloma there. And I'm just thinking we could get more information, but if he doesn't,
That treatment point of view, you can do lavage, okay, which make you good information about neutrophil versus lymphocytes.
right. I think Sumit, having seen him for much longer, may have
Yeah.
a better view. I'll have a word with Sumit also after this and convey all this to him.
Good.
Yeah, we will take it forward. I'll probably bring him back to MDD next time with Bhavin and Athol as well to pick their brains on this, if he has any. So this is the last patient. He's a slightly younger guy, a driver with the police force, 54-year-old guy, married with 2 children, never smoker, recently diagnosed diabetic and a regular walker, 5 to 6 kilometers a day in yoga till June this year. Now he complains of left shoulder pain for the last 6 months, breathless on walking, using the washroom, changing clothes also. The past 3 weeks makes him breathless. No cough, no other autoimmune history of significant, no family history of lung disease, had cervical lymph node TB 7 years ago. His ANA was positive outside, and the ICMR lab was 1 in 200, 1 in 320 outside. Myocyte is blot negative, HP panel negative. ESR was 106, CRP 139. CCP and the rest of everything that was workup was done was negative. And his treatment history was he was given everything by the physician before seeing me. So I stopped everything. Prednisolone, NAC, nintedanib, MMF, theophylline. I stopped everything and just started anti-reflux measures. Next slide. And this is his lung function. 17 September, 24th September, not just a week's gap between the two. Prahlad, the 67, 62% predicted. DLCO is low, but he's walking a fair distance, 96 to 97. Next slide. Yeah, CTs. So there is serology positivity to keep in mind, and there's left shoulder pain, CRP, ESR both high, as you all saw.
So this is his CT from 16th of September this year. Not much happening in the shoulder joint in terms of at least osteoarthritis. The one thing which is interesting was his lower end of the esophagus was quite patulous and dilated. That looked like something might be here as a soft tissue lesion. So which at that point in time, they've given some oral contrast and we've looked at the esophagus. So there's this soft tissue, benign looking pathology attached to his esophagus. Could be a leoma or leiomyoma in there, but doesn't look like anything which is contributing. As far as the lungs are concerned, this is what we are seeing. There is extensive areas of ground glass opacities with peribronchial distribution. And as we come down, you can see some areas of prominent bronchi, predominantly bronchocentric ground glass opacities with mild traction dilatation of bronchi towards the lower lobe. Both upper and lower lobe involvement, pretty much bronchocentric in nature. Not much in terms of nodules, not seeing any honeycombing, not seeing any cystic changes at all in there. With a serology positive ground glass, first thing would be to make sure there is no secondary infection, atypical infection. But this looks more in terms of an inflammatory process where I would be thinking in terms of a CTD, ILD, more than anything else. Not very typical of HP, but HP would be second. So infection, atypical infection, CTD, and then would consider HP in that order.
Sure. And the questions I really had on him was he has diabetes, fibrotic ILD, left shoulder arthropathy, hiatal hernia with an omental herniation. So the rheumatological review has happened since I made these slides. And Varsha, our rheumatologist, suggested prednisolone in a tapering dose with MMF to be started. So,
but CRP is too high. Unless there is an infection, we don't see that much high CRPs, in usual ILDs.
Right. So that's why I wanted her opinion. And it's been a while. He hasn't really had any fever or got much worse. I've just told him wait. And I think he started the steroids. I've not yet got feedback whether he's better. She started a fairly high dose, I think 40 or 50 milligrams, because she felt the shoulder arthropathy was also related to this. In fact, I'm just trying to pull out her prescription if I have it.
Monoarticular shoulder involvement is very unlikely in most of the inflammatory conditions, unless it's a poly. I think in these cases, a PET scan may be very useful. Whether we may be missing something, what's the reason for CRP is persistently on the higher side?
No, this has just been one value. So what Varsha has recommended is to give him mycophenolate 503 times a day and started with 50 milligrams of steroids once daily. And he's going to come back, and she hasn't really mentioned a diagnosis here, which is why, she's suggestive of underlying CTD, NSIP-OP pattern, as Vimal had said, and to meet her in 6 weeks. That's about it. So we would, you'd look at this as a connective tissue disease, ILD, undifferentiated, Mithun? Or
I'm not sure of the CTD diagnosis because ANA is positive, that's all. And very high. When you get a very high values of ESR and CRP, we should be careful because ESR and CRP can be high ESR can be high in Sjogren, those type of diseases. CRP when very high means there may be either infection or malignancy or something. I usually, and if it is persistently high, if it's only one value of value of CRP is okay. We need to see whether the CRP is persistently high.
So I think I need to check with him how he's doing. If he has started the steroids, how he's doing, or if he hasn't started, he's waiting for my opinion, I will check with him. Prahlad, what would you do?
Get his immunological status done. HIV status you have done?
No, I haven't.
He's a police driver.
Yeah.
I mean, I'm not saying that way, but I'm just telling you because this is pretty common disease in these departments. Okay.
Okay.
So we should do actually this workup.
I'll get his HIV checked.
And Mithun, I completely agree with Mithun that some infection, hidden infection, we should not miss, which probably maybe lavage may helpful. Okay.
I will.
And steroid 50 milligrams, certainly not because he's a diabetic, right?
Yeah. In fact, I was also surprised that I don't think he started it. He's going to wait to come back to me. I haven't yet had an opportunity to chat with Varsha on this. And I think he stays quite far off. So he met her, and then I need to have a chat with her. Yeah. And do you think you would take a surgical opinion on that omental herniation, Vimal? How bad is it?
It's not bad. I think it is an incidental thing, and I would not do it. Unless and until he's a lot of reflux, I would not do anything because I don't even think that is causing him much trouble.
That's not fair. Sure. Great. Yeah. Super. Thank you, Asmita.
Thank you.
Asmita, you're on mute. We can't hear you.
Thank you so much, Vimal Raj sir, for explaining that peridiaphragmatic, what is it? PDAF sign, right?
Yes, peridiaphragmatic inflammatory fibrosis.
That was very interesting because I was always worried, which is it? And thank you, Praveen and Venugopal sir for presenting the case, and Shobha madam for presenting the case. And I think the next meeting we will have on 28 November. What do you say, Rajan sir, right?
Yes, absolutely.
Yeah.
And thank you for everyone who joined in despite NAPCON and all the other commitments everyone has. We had a lot of eosinophils in today's MDD.
Yeah, I was like, that was a chance finding, and that's why I put both the cases together, because I believe that this particular concept of a newer classification is so new. Most of us are not clear, like we ourselves are not clear whether it falls into this category and that category and all. So just to have a doubt that whether eosinophilic pneumonia will come in the territory of ILD or not. That's it. Thank you.
Thanks, Vimal. Thank you.
Thank you
very much.
Bye-bye.
Thank you.
Prabhu Desai sir, thank you so much.
Thank you very much, Ashwin.